Thank you. My name is Dr. Pasakon Wanchaijiraboon. I'm a medical oncologist and also a vice director of the hospital corresponding for the AI and innovation in my hospital. And this will be our experience in the very rural area in Thailand because my hospital is located in the eastern part of Thailand. We corresponding for the half of the eastern part next to Pattaya. I think you know Pattaya as well. So and thank you, HI, for having me for these topics. And this is my disclosure and disclaimer. For the cancer is the number one cause of death in Thailand and continues to increase. And lung cancer is the second leading cause of death for both men and women in Thailand. Because of the 80% of the cases are found in stage 4 at the first presentation. And the reason why the stage 4 at presentation is so much in Thailand is because Thailand still lacks of the clinical practice guidelines of the lung cancer screening and also cannot reimburse in the policy for the lung cancer screening. And however, based on the National Prevention and Promotion Plan in the next 10 years from now, that is regarding the lung cancer, it will focus on the conducting the studies for the appropriate screening method for Thailand, which includes cost effectiveness analysis of the various screening approach, in which previously the most expensive national cancer screening was for cervical cancer at $11. So for the Lodo CT at $65, which is more than 6 times higher. So I think that it may be difficult to approve from the government. And however, if using the chest ray or the chest ray AI, the cost may be just only the $7. So, and given that the majority of the Asian women, including Thailand, who develop lung cancer, approximate 70 to 90% have no history of the smoking. So, I think that in Thailand, maybe it may be more quite a big number than in the guidelines. So, in my personal, in our institutional opinion, in areas where the screening will be implemented, the guideline for the average person should be used for the screening similar to those in Japan, where everyone over 40 years of age receive a chest ray, but the high-risk individuals undergo the low-dose CT. Like in Dr. Yuichi from the Sanu University provide the opinion that because access to the chest X-ray is still easier than the CT, using the chest ray would allow the 72% of the patient to access the screening. And however, we know that the problem we will encounter with the chest X-ray is a missed lung cancer diagnosis in all 12 positions as shown in the image. By the inspiring this paper from Ramathipati Hospital, which received lung cancer patient referral from all over the country, the retrospective review of the previous films, they found that 80% of the patients had missed lung cancer diagnosis. There is very inconvenient truth of Thailand. So of which of the 80%, that is 56% are missed by the radiologist. And in another 37% of the case, despite the radiologist reading and referring of the physician did not document the abnormality. So additionally, Thailand health workforce about the radiologists, we have only 2,400 for the population of 70 million. So the mission for the radiologists to reading every chest ray is a mission near impossible. So this result in the 90% of the reading being performed by the non-radiologists, which is the reason for the very high rate of the mixed lung cancer diagnosis in Thailand. So with the advent of the AI assistant in chest ray interpretation, the Royal College of the Radiologists of Thailand has been conducting testing to help administrators and physicians make more appropriate selections and use their decision. From this testing, it can be seen that the detection capability for the abnormality differ across brand, which the ROC1 performing best when compared to the 4 radiologists at the B reader level, as shown in the image. And even within the same brand, each color line represents different detection capability. But to summarize in this slide, the overall capability of the chaser with AI right now, we must know about it may help to increase the sensitivity at the minimum from the 20% to 80% at the present. So From the experience of our cancer center with support from the ASTRA and also the KIO, we have found that at our hospital, we conduct a study similar to the Ramathibodi Hospital, but with our use of the AI assistant, we found that there was approximately a 20% rate of the missed lung cancer diagnosis. This led to the implementation of the phase 2 in a asymptomatic checkup group of the healthcare workforce, more than 3,400 staff members, which this study is ongoing. And we, okay, and we continue to receive the support to extend this to community hospital to our network. From over 50,000 shared X-ray, we found 4,000 nodules with 24% being the high-risk nodules. For confirmation, we are in the process of following up the patients. The case from our limited implementation of AI community, we found that the hospital chose between manual push or auto push system. They select manual push because of concern of the quota. This led us to discover interesting cases such as a lung cancer patient who has detected by AI at my hospital, but was not detected at the community hospital because they has not yet performed the manual push. But when the manual push, it was found that the AI successfully detected. And when the previous X-ray films from 1.5 years of these patients, which was taken for other reasons, was manually pushed in the system, it was found that the opacity has already been present before. After finding in this at my hospital, the CAT scan was ordered, which revealed stage 4, stage squamous cell carcinoma. And if it had been detected 1.5 years ago, the patient would likely not have progressed to stage 4. I also learned that when implementing the AI, one should not limit quotas and should not choose manual push because there are chance of the misdiagnosis. So the recognizing the importance of the shared X-ray and AI screening, we have just finished the fundraise a total $300,000 to purchase a mobile unit for a community with for the community screening shared AI of the people aged more than 40 years old. And so we discovered another problem. Even though the lung nodule were detected by the AI, there was no referral or additional investigation. However, the central office could be notified through the notification system. This led us to develop the next phase, which is opening a high-risk nodule clinic. So this is a new flow that we will apply this in this month. This involves the opening a high-risk nodule clinic will begin, and it will implement active follow-up by searching for and contacting the patients to undergo the low-dose CT or the chest CT scan and continue with the treatment. And the last two slides, I want to raising something about another factors that needs to be prepared after the screening detection in the rural area or in the low middle income country is the development and MDT system and surgical team. Our cancer center has received support so much from Assistant Professor Punnarak Thongjaran from Sirirat Hospital, who is also the president of the Society of the Thoracic Surgeon of Thailand. Now we can perform the surgery regularly, and over 60 patients have undergone the VATS procedure in the past year. And for the last slide, the summary of the practical use of the shared AI for case in Thailand and for cover the missed lung cancer diagnosis and for missed by the radiologist, AI should help bridge this gap. And for cases ignored by the referring clinician, the use of the notification system, monitoring system, and high-risk nodule clinics should help. Additionally, the preparing and MDT team will enable to comprehensively reduce the mortality rate from the lung cancer mortality. Thank you very much.